All right, welcome to Module 2, lecture on acute coronary syndrome. This is my very favorite lecture, so buckle up. We've got a lot of content to get through, and it's going to be fun. So ACS for short, right? Acute coronary syndrome. It all starts with coronary artery disease. And so the problem is that you've got these coronary arteries, so these arteries that feed the muscle of your heart. And like all the tissues in the body, the heart muscle needs oxygen-rich blood to do its job. So as these lipid deposits build up due to endothelial injury, so these injuries are caused by things like hypertension, smoking, high lipid counts, diabetes, infections, different toxins. So this endothelial injury from all of these other things we just talked about leads to this fatty streak, which is where the lipids get into the smooth vessel of the artery, a smooth muscle of the artery, sorry. Then that develops into a fibrous plaque, which then turns into a complicated lesion. And a complicated lesion is when you have like a plaque rupture or you create a clot, also known as a thrombus formation, and it leads to this narrowing or occlusion of the coronary artery. And so you don't get the blood flow that you need to your heart. And then your heart gets cranky about it. So acute coronary syndrome is this pathway starting with angina, which is just a fancy word for chest pain, all the way to myocardial infarction. So it's this continuum that starts with angina and goes to an actual heart attack. So it's caused by this discrepancy between how much oxygen you have and how much oxygen the tissues of the heart need to do their job. So this lack of blood flow creates ischemia, and the ischemia is what causes the chest pain. Okay, so whenever somebody is experiencing chest pain, you need to think ischemia. Okay, so chest pain is always bad. We always want to treat it very seriously. We always want to act like it is life-threatening until we rule out the fact that it is or not. So if you ever have a question where it says that somebody has chest pain, that's always the answer. Okay. So it's, again, this discrepancy between how much oxygen your heart needs versus how much it's actually getting. And your body deals with that ischemia by saying, hey, something's up, and it releases that pain response, okay? So there are other things that can cause chest pain. So scary things like an aortic dissection, where you actually have the separation of the muscles of the artery there. Pulmonary issues like pneumonia, pneumothorax, a PE can all cause chest pain, an aortic aneurysm. You can have musculoskeletal things, so costochondritis, which is where you get this inflammation of the cartilage that connects your ribs to your breastbone. And cervical radiculopathy, that is inflammation of the nerve root in your spine. Okay, pain can radiate to the neck, back, shoulder, hand, fingers, etc. So it does kind of follow that same pathway as we'll see of cardiac chest pain. Pericarditis, myocarditis. So pericarditis is that sac around the heart that gets inflamed. Myocarditis is the heart muscle itself gets inflamed. Sickle cell crisis, we're going to talk about later. Psychiatric disorders, so things like anxiety, right? Panic attacks, they can cause pain in your chest. And it can really feel like you're having a heart attack. So you'll see young, otherwise healthy people coming in with panic attacks, convinced they're having a heart attack, and because it feels so much like that. GI issues, so GERD, if you've got an ulcer, and then herpes zoster, specifically shingles. It kind of can go underneath that the breast there and mimic the same location of the pain. So we've got this case study that we're going to follow to help us understand ACS. So MP is a 58-year-old white male who visits a local health clinic for an examination. He tells the healthcare provider that he occasionally gets indigestion when he mows the lawn. So a lot of times people will confuse cardiac pain with indigestion, and that's what they'll call it, especially like women, older women. They always say it's indigestion. He says that the pain does go away within 5 to 10 minutes after he stops and rests. So you will learn that this is a very important detail, that his pain goes away with rest. Okay, so tuck that away in your brain. When you're getting a health history, what kind of risk factors would you ask about for coronary artery disease? So we've kind of already mentioned a couple of them. And I'm sure you're familiar with them just because it's pretty common knowledge. So things that are non-modifiable is your age. Males are at higher risk. Different races are at higher risk. Just genetics. If you've got somebody who's died of a heart attack in their 40s or 50s, you are more likely to also die of a heart attack in your 40s and 50s, or at least to experience a heart attack. And then things like peripheral artery disease, diabetes, renal insufficiency, a prior MI, or a stent. You can't change that you have any of those things. However, the things that are modifiable are things like sedentary lifestyle. You will see in almost everything that we talk about that smoking and alcohol abuse are risk factors for it. So both of those things are really horrible for you, in addition to things like obesity. Diet, psychological states, so things like stress, depression, anxiety, all exacerbate this. You can control your chronic conditions or not. So the better, like for example, your blood sugar is controlled, the less likely you are to have ACS. And then drug use is bad for you, turns out, specifically methamphetamines and cocaine. Your heart particularly does not like those, puts them under a lot of stress. All right, let's talk about presentation. So your typical presentation is that I have an elephant sitting on my chest, right? They'll complain of chest pressure. Sometimes they say it doesn't feel like pain. It's more like pressure, and that's the phrase that they'll use. But sometimes they just say it feels directly like chest pain. And that pain, if you look in the picture there, the reds is the center, that elephant on your chest kind of sensation, but it can radiate either to the left or to the right of the sternum and then up into the neck. And that radiation into the sides of the chest can actually go down the arm into the shoulder area, okay? And it's usually one side or the other. They will be really sweaty, so diaphoresis. So one of the tests that we do for a heart attack is to do an EKG, which involves putting 10 stickers on somebody's chest and hooking it up to some wires and getting this picture. We're going to talk about that in a second. But sometimes the patients can be so diaphoretic you can't get the stickers to stick. They just slide right off. And then a lot of times they're pale. They're not getting good cardiac output. So they're not getting good perfusion. And so therefore they're going to have some diaphoresis and they'll be pale. Now, the trickier one is your atypical presentation. So a lot of times in females, people that are older than 75, diabetics, people with renal issues, or dementia will have this atypical presentation. And so they won't complain of chest pain. They'll complain of things that are more GI related, like nausea or indigestion. There's that word, indigestion. They'll be short of breath. And that might be their only presentation is shortness of breath. And so you think, it's a pulmonary issue, when in reality it's a cardiac issue. They'll also complain of fatigue, like overwhelming fatigue. They could be altered. And then they'll use the phrase discomfort. So you ask if they have pain and they're like, it's not really pain. It's more like discomfort. And so whenever you hear a patient say that, take it seriously because they could be having a big fat heart attack. Okay. Important distinction is stable versus unstable angina, okay? So stable, of course, is the lesser of the two. It follows a similar pattern. It lasts about the same amount of time. The intensity doesn't really change. It's associated with either exercise or stress. Something brings it on. So you're doing something and then it starts, okay? Whenever you rest or take nitroglycerin tablets, it goes away. The pain usually lasts between 2 and 5 minutes, so it's short-lived, fairly manageable, okay? So when we're talking about our friend who was mowing the lawn, he would be considered stable angina. He was mowing the yard, which causes this discomfort, and when he stopped mowing the yard, it went away. Okay. Now, on the flip side is unstable angina. So, unstable angina can occur with exercise and stress or without. You could just be sitting on the couch watching TV and you start experiencing chest pain. It increases in frequency, severity, and duration. It is not relieved by rest nitro, and it's a significant change from the pattern of your stable angina. And typically it lasts greater than 10 minutes. Okay, so this is a worsening of the stable angina. Okay, so we are going to jump back to our case study, guys. So MP's health history and physical examination reveals the following risk factors for coronary artery disease. He's got a family history, he's a smoker, he has a sedentary lifestyle, he has a high-fat diet, he's got a high blood pressure, and he does have a high BMI. So I'll put him at risk for coronary artery disease. I jumped ahead of myself. So based on the presence of these risk factors and MP's reports of indigestion associated with activity, we talked about how he's got stable angina, right? Now this slide is money, okay? It's really awesome and helpful, and it's my favorite. So, and I will post a better shot of it for you guys on the announcements. So this is a progression of acute coronary syndrome, okay? And it goes from stable angina to unstable angina to an NSTEMI, a non-STEMI, and non-ST elevation myocardial infarction, and then to a ST elevation myocardial infarction. So we're going to piece out what STEMIs are here too. So stable angina. If you look here, you've got a picture of your artery, okay? And then you've got your little plaque here. And then you've got this little thing that looks kind of like a dinosaur footprint, okay? So this is where you've got a plaque that's forming. Whenever you start doing some activity, something that increases the demand on the heart, your blood vessel can't dilate enough to get enough oxygen to the heart, and so you start experiencing some demand ischemia, but it's not actually causing any damage to the heart at this point. Okay, so this is a stable angina. If you look below that, it says ECG. That's your normal ECG. That's exactly how you want it to look, so no changes are happening to your ECG at this point. And then there's this lab value that we use that's specific to cardiac muscle damage called the troponin. So with stable angina, you'll have no changes in your EKG and you will have normal labs, normal troponin labs, okay? A troponin is part of your cardiac enzyme panel. Now when we jump to unstable angina, you've got this plaque that has some kind of thrombus formation or something that's causing a partial occlusion of the vessel. So this pain is unstable. It can occur at rest or with activity, and it can be progressive. So if you look at our little dinosaur footprint, we still don't have any damage to the heart yet, but we do have an issue with supply. So we're not getting enough blood flow where it needs to be. So instead of demand when we're doing activity, it's now a supply issue. We're not supplying adequate oxygenation. So with unstable angina, you can either have a normal EKG or you can start getting some of these ST changes. So if you look at the middle one, there's this little bump at the end and it's upside down, okay? That's called a T-wave inversion. We're going to talk about that more here in just a second. And you can also get a ST depression. So it looks like on the back half of that EKG rhythm that somebody kind of sat on your line, okay? That's what an ST depression looks like. However, you still have no changes in your troponin. So with unstable angina, you can have EKG changes or not, but your troponins are going to be normal, okay? So we're not infarcting the heart, so we're not causing damage yet to the muscle of the heart. Now, when we jump over into NSTEMI, which is just a non-ST elevation, so we're not going to have any ST elevation in our ECG, this plaque rupture and thrombus formation causes this partial occlusion to the vessel. So it's occluded so much so that we start causing some damage to the myocardial tissue, okay? But it doesn't go all the way through. So it's subendothelial, so it's just kind of on that part of it, but it doesn't go through the full layer of the muscle, okay? So with an NSTEMI, you are going to start seeing EKG changes, okay? Same thing, you're gonna have the T wave inversion, so that last little bump is upside down, or ST depression, so that last half, it looks like somebody sat on it. But with an NSTEMI, now we're changing our troponin levels. We're gonna start elevating our troponin levels, okay? Because we are causing damage to the heart muscle. Now, when we get into STEMI, so STEMI is the worst of all of them, okay? So we have a complete occlusion of the blood vessel. We are damaging the full thickness of the muscle, okay? And then with our EKG, we now have the back half of our EKG's got this big bump or a little plateau looking thing. That is what the ST elevation part of STEMI is. And then, as you would expect, we are causing damage to that myocardial tissue, and so we will have a bump in that troponin level, okay? So NSTEMI and STEMI, you're gonna have changes in your labs. NSTEMI and STEMI, you're gonna have changes in your EKGs. When we're talking angina, we have normal labs, and stable angina, no EKG changes. Unstable angina, you may or may not, depending on how severe, okay? So spend some time with this slide. It's very helpful. Okay, so when we're talking about ACS, priorities are everything, okay? Why do you think that that would be the case? So the problem is as you are robbing the tissue of the heart, or muscle of the heart from oxygen, you can start creating irreversible damage, okay? And it only takes 4 to 6 hours for this damage to become irreversible. So whenever we're talking priorities for acute coronary syndrome, EKG is the gold standard because we need to get a picture of the electrical activity in the heart so we can tell if we've got EKG changes or not, because that determines the interventions that we take, okay? If we don't have EKG changes, then we are not dealing with an NSTEMI or a STEMI, okay? ONAM. ONAM is short for oxygen, nitrogen, aspirin, and morphine, okay? It's super quick to put some oxygen on somebody, so you're gonna do that first. We want to give nitroglycerin to help determine if it's a cardiac chest pain or not, and how severe it is. If we have stable versus unstable angina, okay? Remember, with stable angina, my nitroglycerin is gonna make it better. With unstable angina and further progression of ACS, my nitro is not gonna help, okay? Aspirin, we're going to talk about some more in a second. It's got a couple jobs, and then morphine is going to help decrease how much oxygen the heart needs and deal with pain. So we'll talk about that too. So make sure you know priority interventions for ACS because they're very important. Okay, so labs. Again, we've talked about troponin. Normal is very small, so anything less than 0.0 or 0.1 is considered a normal troponin. You shouldn't have troponin in your bloodstream normally, okay? We have other cardiac enzymes, CK and CKMB. We use those. They're not necessarily specific to the cardiac muscle, but they elevate at different times from the troponins, so it helps us know where we are in the progression of our myocardial infarction. So that's why we draw them. We also would draw a CBC and a CMP. For example, if you're really anemic, that can cause some myocardial ischemia, okay? CMP, we can tell if our electrolytes are out of whack or if we've got some renal function issues. We want to know our clotting factors, PT, PTT, INR. And then we will also want to know our cholesterol levels because those all contribute to the development of ACS, right? Back to the troponin, it does elevate within 2 to 3 hours, and it stays elevated from 10 to 14 days, okay? So it doesn't take very long for these troponins to elevate. And we'll do what they call serial troponin levels. So they'll draw one initially, and then they'll draw one usually an hour later or like 90 minutes later. And then if somebody gets admitted to the hospital trying to figure out if they're having a heart attack or not, they'll do them usually every 6 hours. EKG. So remember we talked about EKG. It's really important. You want an EKG done within 10 minutes of the patient's report of chest pain or their arrival to like the ER, okay? Because it helps determine our actions. Again, EKG changes indicate that we've got some ischemia happening potentially, okay? We'll also do imaging like an echocardiogram and a chest x-ray. Echocardiogram usually, it just looks at the kind of structure of the heart. It helps us determine if there's any valvular issues, if we've got cardiomyopathy. It's really helpful in heart failure, determining how much cardiac output we have, and things like that. But an echo is not something that we would do like in the acute diagnosis period. It would be something that we would do after we do all of the initial interventions, okay? So an echo is not something that we use to determine if somebody's having an MI initially, okay? It's something that we would use to follow up to get more detailed information after we've determined if they're having a heart attack or not. So that's really important for you to know. Chest x-ray will help us know if we have, again, any cardiomyopathy or if we have any pulmonary issues. And then stress tests. So stress tests gives us info on the workload of the heart. So we put them either on a treadmill or we can do a chemical stress test where we mimic exercise, and we're looking to kind of poke the bear, okay? When we put them under stress, do they have any chest pain or shortness of breath or dizziness or whatever it is that brought them in that made us concerned that they could be having a coronary artery event, okay? We're going to talk about this ACLS pathway on Thursday. So this is what a normal EKG looks like. Okay, you've got your P wave, it goes into your QRS complex, and it's followed by that T wave. Okay. So when you are having an MI, the top one is what a STEMI looks like. Okay, so instead of having your PQRS, where it goes all the way down to that baseline, it stays up here. Okay, and gets elevated. It looks like a little hill. Okay, so that's what ST elevation looks like. Now with the end STEMI, it looks like somebody sat on your line. Instead of it being elevated like that, it looks like somebody sat on it. So the whole ST segment is depressed. And then a T wave inversion, this back half here is upside down. So this is an EKG of an end STEMI, okay? And your EKG is split into 12 different viewpoints. So if you look here, you've got a Roman numeral 1, Roman numeral 2, Roman numeral 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, and V6, okay? These are all different viewpoints of the heart. And it's like if you're taking a photograph of something, you take a picture straight on, and then the EKG is more like a photographer doing a photo shoot where you're taking a picture from lots of different angles, okay? So that's what a 12 lead is. It's split into 12 parts. And if we jump over here to the second half of it, you can really see this T wave inversion in the V1. You can see some ST depression in V2, ST depression in V3, ST depression in V4, ST depression in V5, and in V6. So this whole second half is showing that you're having some oxygenation issues. Not completely blocking, but we are definitely causing some damage to the heart at this point. Now this is a STEMI. So same kind of setup, it's a little bit different, it looks a little bit different, but you can see your Roman numeral 1. Now when we go to Roman numeral 2, you see it looks like a little hill. Roman numeral 3, another little hill. AVR has depression, AVL depression, AVF has elevation. V1 depression, V2 depression, V3 depression, V4 we've got a T wave inversion, V5 we've got ST elevation, and V6 we have ST elevation. So any ST elevation would be considered a STEMI. And this is our little friend Kermit. I have to throw these jokes in here. So despite what you'll see on Grey's Anatomy, we are not, we don't shock asystole. It doesn't do anything. All right.